A little personal flashback before I introduce our next speaker, who's Joseph Graham. When I was a teenager in Brooklyn, I would get on the Coney Island bus and go to Manhattan on the subway and read books for the blind in science. And then because I was a science major, and then they gave me a cardiology book because I could pronounce the words, but you had to explain the pictures. And I can't tell, like a lot of women, the right parietal lobe isn't so developed, and I couldn't tell left from right, which is why I'm not a cardiac surgeon and why I'm a psychiatrist. Joseph Graham is a board-certified cardiothoracic surgeon who completed his residency in cardiothoracic surgery at the Bowman Gray School of Medicine of Wake Forest University in North Carolina. He is well-versed. I also would put on, by the way, a British accent when I was reading. Didn't come across well. He is well-versed in all aspects of cardiac surgery, including routine coronary artery bypass grafting, valve replacements, complex aortic replacements, mitral, tricuspid, and aortic valve repair, stentless aortic valve replacement, off-pump beating heart surgery, and left ventricular resection. Dr. Graham has received additional endovascular surgical training and performs endovascular surgical procedures including iliac, renal, subclavian, superficial femoral artery, and below-knee arterial revascularations. All right, well, this has been a great morning. You all know why you're here, and I hope you tell your friends about it. And questions, again, by the microphones. And at 9:30, I'll introduce Dr. Whipple to just say one more thing, and then we'll have our break with the exhibitors. Okay, Dr. Graham.
Good morning, and thank you for letting me have the opportunity to present something about the robotic surgery. Robotic surgery is, I think, a relatively new tool for us, especially in cardiothoracic surgery. It's, I think, it's sort of, if you looked at it in the sort of the verse of where we stand in cardiac surgery today, it's sort of like when they first started to do open heart surgery. I think we're sort of in that phase. There's been 4 or 5 centers developed across the country where the majority of these procedures are being done in bulk. And then, according to the STS database data, about 85% of the reporting programs in the country are doing 5 cases or so per year from a cardiac surgery standpoint. So we're at the point of now getting the technology worked out and being able to go forward. Also, for those of you who are unfamiliar with the robot, let me tell you a little bit about the history of it. The current robot that's being used was designed for the military use as a remote surgical device for the field surgery. I really think from a practical standpoint that will never occur, but it was a nice concept and allowed the development of the robot, which was eventually purchased by the Davinci company, and they have marketed it and brought it forward. The current computer technology of it was designed for cardiac surgery. The practical applications of it were actually better marketable for prostate surgery and gynecology, where it's getting the majority of its use. But I do think we're still at the point now where we don't know where the ideal usage is going to be. It's a very broad-based technology, and I'm going to try and go through that and point out some of the things. And we've had it at Ogden Regional for about a year now, and our experience with that, I have about 75 cases now of different things. I'm going to try to go through that and point out some of those things. Again, conceptually, if you looked at why they decided that the robot would be used, I think probably back in the Clinton era, we all started thinking about how could we do things more minimally invasive because healthcare was going to change. We're looking in the face of healthcare change now, but in addition to that, we've also got an aging population. Most of our people when I was training in cardiac surgery, they used to say this really isn't an operation for anybody over 70 years of age. I always laugh about that comment because most of the people I operate on are over 70 years of age. And so that's kind of where we've come to in the course of about 3 decades. I think that so now when we start thinking about how could we make this less invasive, surgeons were faced with 2 or 3 situations, especially in cardiac surgery. We were faced with an issue of stents were improving. When cardiac surgery first started, we didn't have stents. Then stents began to improve to the point where stents were much more acceptable to the population, and they would be to any one of us, too. If you could have a stent and be out of the hospital the next day, why would you have an open heart surgery that's going to take you a longer time? Our feeling about that is that obviously you have a longer duration with the cardiac surgery, but now we've refined that even further. So if you looked at the patient's true comfort zone, it would probably be in this green zone here. And where would the surgeon's true comfort zone be? It would probably be quite a bit off to the right. And so what had to happen is the surgeons had to take the heat and begin to get a little bit more uncomfortable, move out of their comfort zone where we have been with cardiac surgery to try to go into some type of minimally invasive procedures. And different procedures have been developed, and I'm going to try to elucidate the differences between thoracoscopic and minimally invasive approaches and the use of the robot. But anyhow, here's a paper by Kerry Akins from Harvard about using new techniques, and these were the things that have been written about in our literature over and over again, and there's definitely no end to interest in this subject. Patients, what do patients feel? They would like to have a minimally invasive procedure if possible, and most of them would say they don't want to have their chest pulled open, and we would like to do that as well. I don't think there's any cardiac surgeon who really wants to put patients through that. That's the standard of care. And we've been concerned about trying to reproduce this without opening the chest, and that's sort of where all this technology is headed. So in terms of invasiveness, our comfort zone on that is even a little bit further to the right. Robotics would hopefully put us back in this zone. And why do we say that? Is because with the robotics you get two things that are very valuable. One is you have 10x magnification, which you really don't have even when you're looking right at the heart. Two, you don't have the mobility with the thoracoscopic instruments, which work only in two planes, in and out and right and left, where we have 360-degree mobility with the robotic arms. There is a broad application in cardiothoracic surgery, and just for example, in cardiac, we have 2 or 3 different modalities. From the cardiac standpoint, probably where we have come to is to mitral valve repair, and we can also do redo mitral valve repair. So if somebody has had a bypass surgery in the past or some other type of a heart surgery, we can come along with the robot and go in and do a mitral valve repair without ever having to reopen their chest, which is there's a lot of morbidity and mortality associated with redo heart surgery, and this decreases it, especially in terms of patient standpoint. From a revascularization standpoint, we still aren't at the point where we're going to say that 100% of the cases can be done without opening the chest, because that's really right now impractical. We can do 2 bypasses, maybe 3, if we use the radial artery and both mammary arteries. What has emerged is this multi-vessel small thoracotomy or single vessel small thoracotomy operation, where we use the robot to take down the internal mammary arteries, which makes it a lot easier and not have to open the chest, and then we make a small thoracotomy and do the bypass surgery. In addition to this, it's very applicable to thoracic surgery. I think probably of our cases, 45 of our cases have been thoracic cases. It's really very amenable to use in thoracic surgery. It doesn't require the ancillary support that is required for cardiac surgery, and hopefully I can point that out as well. So we can use it for placement of the biventricular leads like Dr. Lund was talking about earlier. We can, in some of those cases, if the coronary sinus lead displaces, they'll call on the thoracic surgeon to place that lead epicardially, and we can place that with the robot. For thoracic surgery, it is very usable for esophagectomy, for lobectomy, thymectomy. We've done 2 thymectomy cases at our hospital, and we've also done a lot of thymus tumors that would otherwise, that's kind of an inaccessible area for thoracoscopy or for mediastinoscopy, because you're further down in the chest where you really can't get to with a mediastinoscope. And we were able to approach that from the right chest with 3 small holes and do the thymus diagnostic and resection if necessary. Also emerging now with the robot is a hybrid strategy, which I'm not going to spend a whole lot of time talking about it, but the hybrid strategy would say that if we know as cardiac surgeons that our best bypass is the IM8 to the LAD. So if we put the IM8 to the LAD and we have a 90% patency rate at 10 years and even now up to 20 years, then why not, if we have great stent technology, use this as a hybrid configuration and do stents for the right and the circumflex and use the robot to do an LAD bypass. That's an emerging concept that's actually made possible by the robot, and there are some places that are doing this with a lot of success. I think where in the larger centers, like I say, where they're doing this, the stents will be placed either before or after the heart surgery, and then the heart surgery will be done for the IM8 or the There have been several generations of robot, and I think we're probably going to see 5 more generations. I think as time goes by, the acceleration of the new types of robot will occur. But one of the more recent things that has developed between the Davinci S and the Davinci Si is that they developed a 4th arm, where prior to that time we had a camera arm, 2 working arms, and now we have a camera arm, 2 working arms, and a retractor arm. On that retractor arm, they've placed this surgical tool which allows you to do bypass surgery, which is where we would normally do minimally invasive surgery using this stabilizer. We can now put that on the 4th arm and use that to stabilize the coronary while we do an off-pump bypass with the robot. And this would be an end result of a patient who had robotic, totally closed mitral single vessel bypass, IMA to the LAD. And that was with use of the endowrist stabilizer. As I say, most of these things are just recently emerging. This went through its FDA trials in 2008. So this is our competitive advantage, I guess, for the drug-eluting stent revolution. I think now we definitely have cases. I think even more where there maybe used to be a controversy between cardiology and cardiac surgery as to what was the best way to approach coronary disease. I think now we're reaching a middle ground where we can use the robot to do a IMA to the LAD bypass, or even 2 bypasses with arterial bypasses with the robot with a closed chest, and we can also add to that drug-eluting stents, which will give us our best advantage for the patient with a minimally invasive approach. So the hybrid would fit up in the patient's comfort zone, and along with the PCI, it fits in everybody's plan of treatment. So if you looked at an AL algorithm for a patient with coronary artery disease, you would say that if you had a patient with single vessel disease to the LAD, you would have 3 approaches with the robot. One would be to use a beating heart TCAB, which is a combination of use of the internal mammary arteries and or radial artery and anastomose to the side of the mammary, or a arrested heart TCAB. And I think most of the robotic procedures with the bypass surgery have not been done with the arrested heart, simply because arresting the heart is a whole newer complex issue, and I'll get into that hopefully with the mitral valve part of the surgery. The 2-vessel disease, you could use the combination of either the drug-eluting stent or the bypass, and 2-vessel disease right and left would require either both a left approach and a right approach, or they would require stenting of the right. And currently in Atlanta, which is probably the largest center of revascularization in the country, they won't do any right coronary arteries. They just do the LAD and possibly the circumflex and diagonal coronaries, and all the rights get stented. Patients who can't have right coronary stenting then go ahead and have regular open heart surgery. So there is more issues. If you start talking about statistics, it's estimated in this country that there's 2.3 million moderate to severe mitral valve patients. Currently treated 48,000. Severe, there's 220,000. Currently treated, all those fall into that 48,000 category. And so this is sort of the target group, this 48,000, which would be people who might be able to have mitral valve reconstruction with the Davinci robot. Why would you use this? This is perceived to be the growth segment in cardiac surgery, and I believe it is the best, most reproducible procedure. It does require a moderate amount of ancillary support, and that is where I think that more as you get into the procedure and you start refining it at your own institution, you find out that there's a lot more that needs to be done rather than just the surgeon's proficiency. The benefits of repair of a mitral valve over replacement have been known for years, and we would like to say that we do about 75% of our mitrals as repairs. And there's interesting statistics that are now starting to emerge with the robot, which I think is one of its main advantages. But there is a reduced risk of surgical complication with a repair. There's a higher long-term survival with a repair. It improves the function and strength of the heart to have your own valve, more freedom from reoperation. There's fewer complications and a shorter length in the hospital, all shown with repair of mitral valves with open heart surgery with the regular sternotomy over replacement. If you start talking about use of the Davinci robot versus a small thoracotomy, so there were two emerging things that have happened. In the last 10 years, a lot of us started to do a right thoracotomy and actually cannulate from the femoral and do a mitral valve repair in a patient who only needed a mitral valve repair. Now, depending on your referral pattern, those are few and far between because most people that come to surgery need several bypasses and or an aortic valve replacement and a mitral valve and maybe a maze. So when you start adding all that together, you're obviously in sternotomy and you can't do that. If for some reason they've had a maze ablation by an electrophysiologist and they've had stenting of their coronaries and now they come for their mitral valve repair, that's the type of thing that's now emerging in the larger centers as their large population. The right thoracotomy approach was good, but still didn't give us the same visualization that we have with the robot. Let's see if we can... Using that fourth arm, they've also developed an atrial retractor, which I hope to show a picture of before I finish. Repair rate, this has emerged that the repair rate with the Davinci has come to 95%. And repair with open sternotomy is 50% of cases, and the thoracotomy is somewhere in between. And basically, this is the way you look at the heart. I mean, in other words, the way we do, when we go sternotomy, we're looking at the mitral valve, which is underneath the heart. So basically, we come in on the top of the heart, we have to retract the heart up and open the atrium to look at the mitral valve, which is underneath. When we come in from the right side with the robot, we're able to look right at the mitral valve the way it sits. It enables you to repair it much more easily because you can easily see the pathology better than you could see it if you were looking at it from the top or through a small thoracotomy. And I think this is probably the best statistic that we have about the whole mitral valve repair technique. The fourth arm is really nice because we used to, when we did the open thoracotomy, a few years ago there was a technique that started called heart port, which I was fortunate to be able to participate in it, and it went off the market. It went off the market because it was just too complicated to be done. It never had worked out all the refinements of heart port. But one of the things that were left from it was a nice atrial retractor, which you could put in from a minimally invasive thoracotomy, and when the heart was arrested, you could retract the heart. We now have this fourth arm of the robot where we don't have to make that thoracotomy and put that extra retractor in, which is very nice, and you can control that from the surgeon console. So, for example, if this would be a minimally invasive thoracotomy approach to a mitral valve repair or tricuspid or mitral and tricuspid, anything on the right side, and we make this incision just below the nipple line and towards the midline of the sternum, and then underneath the skin, where you see the purple line there, that's where we make the incision, but underneath the skin, we usually open the interspace quite a bit more laterally. And proceed then to do it. Here's the Davinci Robot Set Up, where in the center here, this is the camera arm, this is the dynamic atrial retractor arm, this would be the right working arm, this is the left working arm, and this is an accessory port where the tableside assistant works. Now that's a very interesting concept. I think that probably deserves talking about for a few seconds. This is a total radical change in the way surgery procedures are performed, and I don't think this is really elucidated by the Davinci surgical community, but I think that this is really a true thing. In other words, all surgeries that I was trained to do and have done in my whole life, I've done them. Hands-on, every tight, every knot, done everything there. Now I'm in a console operating away from the operating table. There's a tableside surgeon who's doing the surgery. And in this case, they're tying the knots and they're passing through me through that black port. So it requires a real team effort, it requires a lot of expertise, and it requires a lot of work to get timing down. And that's why, one of the reasons why there's an accelerated learning curve. You'd like to say, well, it's because of the hands of the surgeon that need to work, but really what we do is pretty straightforward and simple. What we don't do is the hard part that people who've never done it before have to learn and get proficient with it. So I've gone through all these different ports. Here's a picture, a cutout of the dynamic atrial retractor, and it really is well designed. It has mobility in all planes, so you can take this retractor and you can spread it only a little bit, or you can spread it all the way. It's really amenable to all types of things. When we do an ASD repair with this, we can approach an ASD repair from the left atrium where we never have done that before. And when we put that into the left atrium, we can actually straddle the defect with these two blades and fix it right in the center of that. And we can adjust it as we sew to make it much more easy to see and fix. Really, there are some very, very significant advantages to the robot, and they'll emerge statistically with time. There just hasn't been enough time. Differences between the, let's say, the mini thoracotomy mitral valve repair and the Davinci mitral valve repair. Obviously, with thoracoscopic and laparoscopic, we have a 2D vision. There's three-dimensional vision with the Davinci robot. I don't know so much about the tremor amplification and so forth, but they do have a tremor factor built into this robot where they have a delay in the motion of the robot arm in case you start to shake. The thoracotomy, the one other thing about the rib ports, so we've all done thoracoscopy, and we've done thoracoscopy for a long time. The ports that we use for that are average between 12 and 20 millimeters in size. These robotic ports are 10 millimeters. So the intercostal neuritis that goes along with robotic surgery is about 70% less than what you have with the regular thoracoscopic. Here's an example of an open mini mitral valve repair with the right thoracotomy. And this elaborate arm here and so forth is a camera-assisted device, but basically a retractor goes in place. You can see the heart there. The surgeon really has excellent visualization. That retractor that I talked about that was with the heart port is this right here, and that actually goes inside underneath this. You poke it out to the other side of the sternum through a small hole and attach that to the left atrium. So it provides your retraction. You can see well. You can do everything, but you still don't have the same visualization as you have with the robot. Here's the robot, same type of thing we're talking about. We have the two-arm working ports. We have the this for example we have two methods to clamp the aorta with the we have two methods to clamp the aorta with the Davinci. One is to use this clamp that was designed by Randy Chitwood in South Carolina. And it's a clamp that we put through a separate hole, and we can actually go in and clamp the aorta with that to occlude the aorta. But there has been an endo balloon, which was also a product of the heart port era, that has emerged as a usable device in this. And so we can pass that up through the aorta and use that for clamping the aorta and arresting the heart, which makes it a lot easier to work because you don't have to worry about that being in the way. Again, the working port is in the center here, and that would be where the assistant works through that port. And he also, basically the assistant will be looking at a video monitor and working through the port, looking in the hole sometime, but mainly looking at the video monitor while he does his work. So he's kind of like in the thoracoscopic mode, and the surgeon is in the other mode. So let me just go to the... let me go right to that interactive part. Let me just skip the second PowerPoint. Let me go right to the interactive. Anyhow, I'm going to try to show and narrate over a short movie of a mitral valve repair in steps.
My name is Mark Galuski. I'd like to welcome everybody.
Actually, we're going to go ahead and play the video of a thoracoscopic or of a lobectomy. If you could just try to do the one on the mitral valve interactive there. Because I think that the best part of this is actually seeing it. It really is a tremendous advantage. Yeah, this is good. Can I go through these slides, or if you just go over to surgical steps there? You can't see it. Okay. All right. Anyhow. All right. Well, that's fine. Why don't you just go back to that second PowerPoint? I'll go through that and show some pictures of that. So I'm going to try to show some of the photographs of the application. And it's really, unless you see this in action, it's hard to see. We've gone through a lot of this material, but in here I have some good slides on the actual device and what we can do with it. We've gone through a lot of this. This is a comparative image of what you would have with this is an off-pump bypass on the left. This is a thoracotomy bypass in the middle. This is the robotic Davinci on the right. Again, you know, for the this would be a multi-vessel small thoracotomy approach where you've taken down both internal mammaries with the robot, and then you go ahead and use these external retractors to do the bypass, which is a lot more comfortable, a lot more tolerated by patients. This is just an example of using the Davinci robot for a beating heart surgery. Once you've prepared it, this is about how it looks. I'm sorry this is out of focus, but it's a good technique. This is a report of a multi-center trial where patients with mitral leaflet prolapse, and this is the typical mitral valve repair that we come across most frequently with mitral valve surgery. This is the P2 to P3 segment of the posterior leaflet of the mitral valve. And when we go, we usually resect that leaflet and we sew the two margins of the other leaflet together and even do a sliding mitral valvuloplasty there. It's much more easily facilitated with the robot, and we use that for this, and I think that's why it has emerged as the main choice. As far as use in from a transhiatal esophagectomy, that can easily be done with the robot. It's very straightforward, and the old Ivor Lewis operation, which we did with a right thoracotomy and an abdominal laparotomy, we can now do that with a 5-port laparoscopy and a robotic approach to transhiatal right esophagectomy, and then do the anastomosis in the neck. Makes the procedure about the same length of time with a significantly lower morbidity. Lobectomy, I think, is going to be one of the main winners with this procedure because this is very amenable to thoracic surgery without a lot of ancillary support. Here's an example of a patient after the surgery. Only the 4 small holes are present. It's very painless for the patient, and especially people who have the mitral valve prolapse. It seems to be more prominent. The mitral valve prolapse becomes worse and becomes a severe phenomenon in women in their 40s. So it really is a very usable technique for them. Epicardial lead placement. This would be an example that I spoke about before of using the epicardial leads for this. Very effective use and very good placement. This is an example of doing a maze atrial ablation with the robot. We can also do that, and we have very good visualization, much better than we get with thoracoscopic, because again, we've got 3D vision, and we also have the ability to work all the way around rather than having to work in just 2 planes. Okay, good. All right, well, I guess we'll just go ahead and hold it there. Do you have any questions about it?
You have talked about clamping the aorta. Presumably we've arrested the heart.
Yes.
How do you do this without bypass?
You do it with bypass.
How do you do bypass without a thoracotomy?
We use the femoral artery and vein for cannulation, and we use the femoral artery and vein for cannulation. So we can, rather than put the cannulas in the aorta and the right side of the heart, we put them in the right side of the heart through the femoral vein.
I'll be darned.
And then the endo balloon. This is what this is. This is a merging of a lot of technologies. So that where we generally give cardioplegia through the aorta to stop the heart after we've clamped the aorta, this endo balloon, which was designed for heart port, will deliver the cardioplegia itself. And then a technology which Dr. Lund showed during his talk, we also use that technology to cannulate the coronary sinus, and we give cardioplegia retrograde through the coronary sinus with a retrograde cannula.
I'm impressed.
It's very exciting, impressive technology, I'll tell you that. Okay. Thank you very much.